Good afternoon and welcome to this instruction course on peripheral ulcerative keratitis, pearls in management. My name is Virender Sangwan. I work at Dr. Surav Charity Eye Hospital in Daryaganj in Delhi, and we would like to share our experience and whatever we know for management of these patients. We have no commercial interest to declare. The co-instructor for this course is Dr. Isha Chaudhary. She is a cornea faculty at Dr. Surav Charity Eye Hospital with me. Dr. Somsila Murthy, she is the medical director at Shantilal Sangvi Eye Institute in Bombay, and J.S. Vajrani from Excel Eye Care from Ahmedabad. What you can expect this course, if you see, look at this kind of a video, you can make out clearly that it is not an inflamed eye, and that is why we called it a degeneration, not a active ulcer, because there is no, and when you put the staining, most of these patients would not have any ulceration. Yes, small minority may have inflammatory terians also. On the other hand, sometimes when you do a pterygium surgery, you may find a picture like this, that and this kind of a picture can also cause peripheral ulcerative keratitis, but here it is primarily a ischemic necrosis of the site where pterygium was removed, and there are multiple ways that it clinically presents. Have you seen a patient like this anytime? This is a young female child of 7-8 years old and no history of any trauma. Parents brought that this is a mass growing on the surface, and they brought for the treatment. This was a fistula connecting to the anterior chamber and this conjunctival cyst, and so when I removed, there was some kind of trauma which child did not remember. This is like a healed Moran's ulcer, and why I am saying healed? Because you don't see cellular infiltration, don't see redness, don't see congestion. So therefore, it's very important to clinically decide whether you are dealing with an active disease or inactive disease. This is a very interesting case. I was called to see in emergency clinic in LVP in 2005, and in my usual style, I said, ये तो perforation है, इसको surgery करना है. But can you see what is remarkable about it? Anyone wants to say anything? That again, there is no inflammation, there is no redness, right? So if there is a perforation, why is no ulceration, no redness, no congestion? Very unusual. In patient did not have pain either. And I, at that stage, I was very young. I was just started my career. I also did not know what it is. When I was doing the surgery, patch graft, the feeling of the tissue field was so unusual. I kept saying to my fellow, ये बहुत अजीब सा लग रहा है, कुछ तो गड़बड़ है. Then we sent everything to pathology, and it turned out to be a carcinoma. I will show the rest of the story in my presentation. So when we are saying peripheral ulcerative keratitis, which means essentially this is the definition, that it is a crescent-shaped destructive inflammatory lesion with epithelial defects, with subepithelial infiltrate and a central edge. It can be non-infectious. We will talk details about the clinical presentations. We'll talk about the differential diagnosis. But very important significance of PUK and necrotizing scleritis, especially if the patient has collagen vascular disease of anything. This has a very serious implication. That means it's not only the eye disease, it signifies that there is a possibility of visceral vasculitis, meaning kidney, liver, heart, lungs, they can get affected. So you should not take it lightly. If you don't know how to handle these patients, maybe refer to a rheumatologist and say that this is very important, that we get to the bottom, that does this patient has any threat to the life. And in literature there is enough evidence, and that is why these patients need systemic immunosuppression. we'll talk about how to differentiate different clinical entities in the differential diagnosis. So our objective of this course is that we will, you'll be able to diagnose common entities of PUK and what is its medical and surgical management, differential diagnosis, immunomodulation, and what is the risk to the life of a patient with PUK. We do not want to have very didactic. Please feel free to ask questions, stop, as much discussion as you want. It's not important what we want to say, it's more important that we answer your questions. So we'll be happy to interact, ask question any stage with any speaker. Next, I would like to invite Dr. Isha Chaudhary to continue with her presentation. Dr. Somsila has a presentation in another session, so she will join us little later. Can you please come and change the, oh, you can go on the other side, yeah. You can upload her talk on the other computer.
I'll switch. So very good afternoon, everyone. So William Shakespeare once said, what is in a name? But there is something in the name. So when we're talking of peripheral ulcerative keratitis, we have the word peripheral in the name. So why only peripheral? So peripheral lesions can range from Tyrion's marginal degeneration to accumulation like a BSK, other PUK and perforations. They can be a pannus, they could be a marginal keratitis. We've seen a lot of peripheral lesions. So what's special about a peripheral ulcerative keratitis? So it says that the word ulcerative and keratitis is in the name. Ulcers can be both peripheral and central. So what's different? Why is PUK always peripheral? So before I go into that, I'll just explain the pathogenesis in a very brief way. So normally autoantigens are not recognized by the body's immune system. However, in this disease, the autoantigens activate the B cells to release plasma cells against the autoantigens, and these autoantigens are then they release more antibodies by activating these plasma cells. These autoantigens and the antibodies to these autoantigens, they combine together and form immune complexes. Now these immune complexes are large molecules. So as our peripheral cornea has...
Can you stay back there?
Yes.
On the cartoon you go back?
Oh, okay.
So does everyone understand in very simple terms when we say autoimmune or immune complexes, what does it mean? What it means is that normally the cornea is not recognized by immune system as foreign. Body has a surveillance mechanism with lymphocytes, and they come sample each tissue of the human body, and if they find there is an alteration or there is abnormality, they signal, they express MHC class 2 molecules, and then they secrete cytokines, tell other cells that there is some intruder because they think that it's not a normal structure. So that is where we call autoimmune, meaning our immune system has turned against us. So that is what, and then the immune system gets activated, then innate system, the complement, all they combine, they are trying to protect us, but they don't realize that it is part of your human body. So that is why autoimmunity is little more difficult to treat, because every cells, new cells come, they will survive for 2 to 3 months, and then again the new cells will start behaving the same way. So we will talk when we are talking about the immunomodulation, why you need to continue for a longer time. At the moment, simple term, autoimmune means there is something alteration in the structure of the cornea or microstructure that is not recognized by the body immune system as self. So there is an important distinction between self versus non-self by the immune cells. Please carry on.
So now we've understood why there is autoimmunity here, and those antibodies and antigens, they form complexes. Now these complexes are large complexes. So if we see here, it's only the peripheral cornea that has access to blood vessels and lymphatics that are associated with them. The central cornea is devoid of these blood vessels. Also, the stromal lamellae, the cornea in the periphery is thicker and the stromal lamellae are loosely arranged. So when these immune complexes are formed, they come and enter the peripheral cornea, but they get stuck in the peripheral cornea because that's the only place where they can enter, and they are not able to move forward up to the central cornea due to their large size, and hence the peripheral cornea. So here, when the immune complexes get accumulated, they activate the complement both through the classical and the alternate pathway. The complement activation leads to release of cytokines, which activate the MMPs, and which in turn leads to the dissolution or the melting of the cornea in the periphery. So the points that lead to just the peripheral part being involved in peripheral ulcerative keratitis is the presence of vessels and lymphatics only in the periphery, the looser arrangement of stromal lamellae and the higher thickness. Also, the peripheral cornea and the limbus and the conjunctiva near it has reservoir of antigen presenting cells that through the lymphatics goes and presents these autoantigens as foreign. So these autoantibodies reside in this area, and the T cells in the tear also exacerbate this immune response. The other thing is that the contiguity and proximity of the conjunctiva, episclera and sclera to the peripheral cornea also expose it to the antigens, and this can get secondarily involved. So we've covered most of these points. Also, the complement C1 and IgM, again like immune complexes, are large molecules and don't penetrate beyond the peripheral cornea. The peripheral cornea also has higher replicative capacity both for the epithelium and the endothelium, which is the immature cells that get affected faster than the mature cells in the center. Also, the area is less sensitive owing to less neural innervation. Immunologically, there is higher expression of MUC4 gene, which when defective does not protect or regenerate the epithelium as it would in normal cells. So we've covered most of these things, and this is a QR code. We have prepared a handbook. You can
Yeah, please go ahead.
yes, so you can scan this QR code and download the handbook that we've prepared. It will have all this information and also the references to what we've quoted.
And please check it's working or not. Then only we'll go to the next slide.
Yes.
Can you go back to your slides?
Yes.
Yes, yeah, the ischemic, this one, next one. Next. No, not backward, far, yeah, this one. See, this is I also showed you that picture. When you do pterygium surgery, there are three kind of problems that can happen. One is something called SINS, surgically induced necrotizing scleritis. I will show you that in my presentation. Then what this picture is typical of a ischemic necrosis, and this probably is due to maybe excessive cautery or healing problem. Third, it can be a infectious scleritis at the site of surgery. So all three are very different, and it's very important to make a distinction because the treatment is very different. For SINS, you need immunomodulation. For ischemic necrosis, you need to promote healing, and for infection, you need to make diagnosis and treat with antimicrobials. So these are the kind of pearls that we will be sharing. And Isha, maybe you can continue with your
clinical presentation.
Clinical presentation, because Somsila is delayed.
Sure.
And if you have any question, please ask, interact. We want it to be very interactive. So far, if there are any questions, please do ask. Otherwise, Isha, you can go ahead with your next
Yes.
talk.
Okay, so when we get a patient of PUK in our clinic, what are we supposed to do and how are we supposed to proceed? As Dr. Sangwan had mentioned initially, that PUK is not just an ophthalmic disease. It has grave systemic implications if missed. So, and a lot of times the ophthalmic presentation is the first presentation of the systemic disease as well. So as an ophthalmologist, we have a responsibility that when we see a patient of PUK, we investigate them systemically and refer them to the right place to get that part of it also treated. So I'm going to start the clinical presentation with two cases. So the first case is of a 70-year-old male who presented to us with redness, pain and diminution of vision in the left eye since the past 4 months. He was already on systemic steroids and topical lubricants when he presented to us, and his systemic evaluation from elsewhere had a raised ESR, but the other tests were within normal limits. He had had multiple ocular surgeries before, TRAB in both eyes, phaco, retinal injections, and he was on anti-glaucoma medications also. The right eye essentially was within normal limits except for a bleb and a higher cupping, but the left eye had peripheral thinning, as we can see here, with an epithelial defect, and there were subepithelial infiltrates as well. So as we treat a normal ulcer, we did a corneal scraping and did not find any growth. We did some basic blood investigations. Again, we found our ESR to be raised, and the other investigations are within normal limits. And as we had no fungal hyphae, no growth was seen, we started the patient on prednisolone acetate 2-hourly, oral prednisolone as well, with the homotropine lubricant, and continued the AGMs he was already on. By day 10, the patient had symptomatically improved. Lid edema was still there, congestion had reduced, but a crescent-shaped thinning was still present. By day 15 and day 25, the patient had improved drastically. So the steroids were tapered and lubricating eye drop was continued. The patient presented to us 1.5 months later with increased peripheral guttering and thinning, and this area was also taking up stain, which means it was without an epithelium. So such a lesion has a very high chance of perforation. So we planned a patient for a TABCL with conjunctival resection. So after 8 months, this patient was doing well. Coming on to the second case, the case was of a 71-year-old male who presented with pain, redness and diminution of vision in the left eye. He was a known case of rheumatoid arthritis, but since the last 3 months he was not taking his medications. He was also a diagnosed case of cardiac disease. So on presentation, his right eye had a scar with superficial vascularization. Left eye had a perforation which was around 3 into 3 mm with iris tissue plugging it. So we diagnosed the patient as right eye healed PUK and left eye PUK with a sealed perforation. So what we wanted to do was to give IV methylprednisolone and plan his blood investigations. But because of his cardiac dysfunction, we could not give him IV prednisolone or take him up for surgery under local anesthesia as well. So we started him on steroids again, both oral and topical, and investigated him. So all his investigations were off the charts. His LFT, KFT, RA factor, anti-CCP, everything was abnormal, both ESR and CRP as well. So these had to be normalized before we could take him up for any procedure or give him IVMP. So we did a physician referral who started him on hydroxychloroquine and supplements along with it, and we were waiting for the LFT to get normalized before we could start methotrexate. So by day 10 on steroids only and after the treatment was started, the patient had symptomatically improved, the chemosis had resolved, the congestion had reduced, and the perforation also had become, the iris plugging had also seemed to reduce, maybe because of decrease in edema. So the same treatment was continued, and by day 17 the patient was much better and scarring had taken place over the area of the perforation. So steroids were tapered and the rest of the treatment was continued. So by 2 months his LFT had normalized and the patient was started on methotrexate as well. So by these two cases we can see that we may or may not find a reason for a PUK, but the management has to be tailor-made for each and every case depending on what are the other associated factors. So essentially a PUK presents with a crescent-shaped peripheral thinning, as we can see here. The edges are overhanging, there is associated congestion, and the central cornea may or may not be involved. If there is diminution of vision, that could be because of the inflammation or the astigmatism the defect is causing. It is mostly unilateral but can have a bilateral presentation, can present only with a defect or be a perforated presentation. It may or may not have an infiltrate, but when there's an infiltrate, a corneal scraping, like how an ulcer is scraped, is to be done. It has to be differentiated from a Moran's ulcer, which is essentially a ulcer which is like a PUK. It's more chronic, serpiginous in nature. It is not associated with scleritis. The pain in a Moran's is out of proportion to the signs. We are not able to find any systemic cause for it, and there's no clear zone of peripheral cornea. So what do we do when a patient with a PUK walks into our clinic? We obviously check the visual acuity. On a slit lamp biomicroscopy, first we assess the patient in an unstained, first we don't stain it. We look at the clock hours of thinning, presence or absence of any infiltrate. If the eye is congested, we have an idea that it is an active disease. Sometimes the patient presents in a quiet eye which may not have an active disease, maybe a thinning because of a prior episode of PUK. Look at the anterior chamber depth, because if there's a small perforation also, the AC may be shallow to flat, and a careful digital tension to assess if the eye is soft. Then when we stain the patient with fluorescein dye, we see that whether the area of the guttering or the thinning is epithelialized or not, because if it's epithelialized, then we may not want to surgically intervene unless it is for optical reasons. We do a Seedles test to look for any perforation, and because autoimmune diseases like RA do have a dryness component, we look for the extent of the dryness as well. If the patient is cooperative, we can assess the fundus. If a scraping is needed, we send the whole thing like a gram stain, KOH, culture. And for the blood tests, now these blood tests are very expensive tests, and not everybody can afford the whole battery of tests that we want to do. So maybe we can start with the basic tests and proceed to the higher ones in case we feel that something is wrong, something is suspicious. So a CBC, ESR, CRP, a blood sugar, kidney function and liver function tests can be done in all cases. And depending on what systemic condition we are suspecting, we can go on to do the other tests, specific tests as well. So there is a whole list of these tests that we can do, and a whole list of signs and symptoms that we can elicit and ask the patient in their history and examination to look for any other conditions. RA being the most common, we can ask for morning stiffness. The small joints are affected more than the larger joints, and such deformities can be looked for in the clinic, and a lot of patients do present with such deformities because their RA has gone undiagnosed for very long, or they have been very reluctant to take treatment for this disease. In the end, I would just want to say that a collaboration with the rheumatologist is suggested, because a lot of times we may not know what is the extent of the systemic illness and what is the treatment that we'll want to give, which is appropriate for the patient. So again, for those who have missed, can scan the QR code here.
Very nice presentation, Isha. Yeah. Any questions or comments for Isha? Or she showed two different cases. One had a clear-cut systemic component, the other one did not. So any of you have any comments to make or any question?
Yes. Sorry?
Can you speak it, doctor? Can you speak?
Brimonidine. So the patient was a known case of glaucoma, had undergone TRAP, had an advanced cupping. So that treatment was going on from before, we just continued it.
Any other questions, comments? So it has been now known that even the medication that are used for glaucoma can cause this kind of peripheral ulcerative keratitis, especially if it's inferior. Yes.
Doctor's question is how to investigate Moran's and otherwise PUK. Is Dr. Dalia said here? Okay. We will, after this, we will have listened to your talk, and then we'll continue with the rest of this. Thank you very much for the patience. So, see, Moran's ulcer is a specific morphological clinical type. And if you review the literature, there is excellent study and done by in our country. There is something called Watson's criteria for diagnosis of Moran's ulcer. So, in Arvind, Dr. M. Srinivasan and their group, along with the group in US, what they did is, okay, we will take clinical diagnosis of Moran's ulcer, and then we will investigate them thoroughly. all, collagen vascular profile, ANCA, we'll do CT scan, we'll do all. And they wanted to see whether it is really true that there is nothing positive in that. So that was a very good, well-designed study, and in that they proved that if clinically there is a Watson criteria fulfilled, you don't need to investigate those patients for etiological diagnosis. You may do CBC, LFT, X-ray test for management. Why management? Because you want a baseline, all these parameters, and if the patient need immunosuppressives, you would want to compare them with the baseline. So doing the diagnostic investigations has two different roles. One as a baseline, parameters, and for etiological diagnosis. So for Watson's criteria, it is a specific type of Murray's ulcer with the crescent shaped, with the advancing edge, the receding or the trailing edge is healed, and there is no scleritis, there is no associated collagen vascular disease, and I think these are the 5 criteria. Yes?
Yeah. So in addition to what Dr. Sangwan said, it's important to know the severity of what you're seeing. So just as a show of hands, how many in the audience would call themselves ocular surface specialists or cornea specialists? Right. So if you are an ocular surface specialist or a cornea specialist or someone who deals with autoimmune conditions of the cornea and the sclera, then it makes sense to go into all this and into the depth of all this. But in 2025, if you're really not managing these conditions on a regular basis, or you don't have the training or the tools to deal with this, my recommendation would be not to do any investigations and to try and find an appropriate specialist who can deal with this, because it can cut both ways. You may have cases which really do not need too many investigations, and you unnecessarily spend time and money, and a lot of investigations are done and nothing comes up. On the other hand, you may have cases which...
Even cases you random investigation, something comes positive,
yes,
and you don't know how to correlate. So then you start chasing that investigation rather than the disease.
So the patient may be over-investigated and over-treated. At the other end of the spectrum, you may have cases which look innocuous but which may have a systemic component you need to really work up, and you might miss that. So my recommendation in a nutshell is that rather than trying to investigate and go into the... Of course, the handbook is there, you'll find all the information. But if I were a comprehensive ophthalmologist, I would just send it to the nearest person who is trained to look at all this.
The investigation, there is another downside, is that if we find something which we don't know and whether it is a cause and effect, and we may mislabel the patient, and then the patient worries a lot that okay, if ANCA positive, and you don't know whether it is really positive or not, and then you may say okay, it is Wagner's. So patient will start looking for that in the internet, and then you may, they start getting worried unnecessarily. So it's very important role that we physicians have to play, that balanced activity. Dr. Dalia said, please welcome and thank you very much.
Thank you very much.
Please carry on with your presentation. Management of perforated PUK.
Thank you very much for the invitation. So I'm going to speak to you today about perforated PUK surgery and beyond. I'd like to acknowledge my mentor, Professor Harminder Dua, who's taught me most of what I'm practicing. So we really don't want to reach this stage, because we know that patients presenting with this situation are going to be losing vision, counting finger, end up with a counting finger vision, 65% of patients. Then if it's unilateral, then mortality increases to 25% in 1 year, and if it's bilateral, maybe 50% increase mortality in a year. So what do we do so that we don't reach this stage? We have to identify the etiology, manage threatening perforation so they don't end up being perforated. We have surgical options for perforations, but the peri and post-operative management are essential, and we have to later on visually rehabilitate these patients. The etiology can be ocular or systemic. The systemic, remember, 20% of them are infectious. So you have to investigate for infectious causes, because you are going to immune suppress these patients, and you don't want to miss an infectious cause for the PUK. The autoimmune causes represent 50% of the non-infectious causes, and that's why you have to also investigate these profusely. So it starts, as my colleagues have said, with the peripheral ulcers. There is a clear zone. It starts to extend circumferentially. And if you have a patient with rheumatoid arthritis, for example, like this patient who've not been very well controlled pre-operative, and you go and do your cataract surgery, you can end up with a peripheral perforation and infection, like in that case. Moorings is a diagnosis of exclusion. So you have to investigate everything before you say this is a Moorings ulcer. It is idiopathic. If you see scleritis like in the lower picture, then this is not Moorings. It's very painful, unilateral or bilateral, and sometimes there is helminthic infection, genetic factors. Hepatitis C can be association, and even other genetic factors can be associated. So what do you do when you meet a patient with a PUK? Very important to take a thorough history, do systematic examination, exclude infection, as we've said, look for immunological factors, don't forget to do a chest X-ray, and look for inflammatory markers. And OCT is very helpful to tell you how thick is your cornea, how much thinning is there, are you about to perforate or not. And it is really, really essential to liaise with your rheumatologist, because sometimes it's difficult to get them on board, because they always say if the joints are fine, then the patient is not one of our patients, and we can't. So you have to have serious talks with the rheumatologist. Whenever we get a PUK which is about to perforate, we admit these patients, give them IV methylprednisolone 500 to 1,000 and give oral steroids, and then with the rheumatologist we can give immune suppression while they monitor the patients. And there are a variety of immune suppressive drugs that are used by the rheumatologist, especially the biologic agents. I'm not going to go much into details of this, but if you have a threatening perforation, you can start with topical and oral steroids. You need doxycycline to reduce the melting. You can put a bandage lens or use a multi-layering amniotic membrane, and I will show you some cases. This patient presented to us with a burnt out psoriatic arthritis. So she stopped her methotrexate because the joints were fine. She came with a PUK. It was getting worse and worse, and we put a multi-layer amniotic membrane on the area of the epithelial defect, but we had to admit her, give her IV MP before, and followed by oral steroids with the help of the rheumatologists, and then she was maintained on 20 milligrams per week of methotrexate, and she had very good vision after. This is another example of a patient who was referred from another hospital with recurrent PUK. This time they were not able to treat with the topical and oral steroids alone. We admitted the patient and we give him also oral and topical steroids were under cover of antibiotic, but the patient was getting worse and worse, and you can see here the ulcer is getting worse by the day. And the rheumatologist investigated everything and said everything is negative, this is a Moorings ulcer. So we admitted and give the IV MP. I hope the video will work. So we did the conjunctival resection. The videos, there is a bit of lag in the videos, I think, when I was loading them.
Yeah, they are going to UK in that.
I wish, because I've got quite a few videos here. So the conjunctiva was completely resected at the area where the ulcer was. Also the area of the limbus and the epithelium was removed. Very good cautery to that area was done after removing all the epithelium at the edge. And then we had an over-the-counter amniotic membrane, which we used, fashioned to the area of the defect, as you can see here. Obviously, if you have the iBank Omnigen is better, but in this case we didn't. And then we used fibrin glue to glue the amniotic membrane on the edge of the cornea as well as the area of the sclera, and you can even glue the conjunctiva on top of the amniotic membrane like in these patients. But having done all the surgery then this is just to show you how we put the glue and then reflect the amnion back on the sclera. And then the patient described that his nose and ears swells every time he gets a PUK. So although the rheumatologist thought this is a Moorings ulcer, but they actually found a diagnosis. That's how important the history is. So, but it didn't change the treatment much, but at least they were convinced, and then we carried on with using methotrexate 50 milligrams per week while we reduced the oral steroids, and then the patient had very good vision, completely epithelialized 1 month after, and this is the patient here 18 months after, completely stable on immune suppression. Now, if you have a perforation, there are different variety of surgical techniques. You can start with gluing multilayer amniotic membrane, tenons or scleral patches, lamellar or full thickness grafts. So if you're going to glue, you don't want to put the glue on the iris, so you do the double drape technique. So put one plastic disc to cover the iris and then the other plastic disc with the glue so that the iris doesn't get in contact with the glue. You can also use autologous scleral patch, and sometimes with time that becomes transparent if you put it on the cornea. And sometimes you get these very complex patients, like this patient I would like to share with you, presented with localized corneal edema, which is unlikely a presentation with PUK, and shallow AC and perforation. She was glued 3 times and getting perforated at different points. But we did the OCT and we could see that they've got a lot of corneal edema. It's not just thinning. And then we did a topography on the other side, and it was undiagnosed keratoconus. All the bloods were negative except for eosinophilia. Then eventually the patient got worse and worse, extensive inflammation up to almost detachment of the limbus. So this patient, we went and removed all the necrotic and all the unhealthy epithelium and stromal tissue, did 200 micron, used the diamond knives to create a 200 micron sclerocorneal disc. So you can use the Mellis dissector after mounting the sclerocorneal tissue on the artificial anterior chamber and do the lamellar dissection limbus to limbus. Then you can actually use a plastic to do the exact area where you need to graft, and then you can split the sclera. You've already dissected the cornea, but you can split the sclera at the same area and then create a stromal, anterior stromal lamellae, where you can put here, you can suture and glue to the area of the defect. So, and then you can actually glue the conjunctiva on top. And this is what we've done with this patient. And the microbiology, we took the tissue, sent it for microbiology, and they did show that there is some small vessel vasculitis, and the patient was maintained on high dose of steroids, which was decreasing 2-hourly DEXA-free with an antibiotic cover. And this is the patient. She had a lot of inflammation post-operatively, which had to be managed with increased steroids and immune suppression systemically. The sutures loosened and were removed within 6 weeks, and then finally the patient was 6'9", unaided. So with these peripheral ulcerative keratitis, the good thing is that the central vision can be maintained for a long, long time because all the changes happen mainly in the periphery. Another patient with bilateral Mohr's ulcer with previous perforation, very large perforation, presented with a large peripheral perforation. So one other technique you can use is that you can use 2 different refines. So this one we used 7.5 and 9.5 refination to create that ring, and you can actually decenter the central one so you can get a thicker rim, and then you take that rim and suture it first before you cut it to the area of the defect, to the patient's cornea, like in here. And once you've got your graft to the area, the size that you want, like in this patient, then you can remove the rest of the cornea. And if it's too thick, then you need to thin it out a little bit so that you don't have a proud edge. Again, these patients have to be followed up with immune suppression. Make sure that you have no leak after you've done your surgery, and then after reforming the AC, and you can glue the conjunctiva on top. And this is the patient in the post-op, done very well. Another option is in this patient's glued multiple times, but the perforation was too big. So you can use the manual to refine, and you need to make the sclera partial thickness and to cut the actual cornea full thickness. So full thickness corneal cut, partial thickness scleral cut, and you can use the punch biopsies to create a round refination, and make sure you make a pupil for the patient and remove any retrocorneal membrane like in this patient, and put suture your graft. And this is the patient's post-op. And then you can make a central graft later on for visual rehabilitation. If you have a large central perforation like this, you can have a large defect. Make sure that when you're suturing, that the surface coapts. It doesn't matter if the inside coapts. So the take-home message is really melting is a sign. It's not a diagnosis. 50% of cases are associated with collagen vascular disorders. It could be a first presentation of a potentially lethal disease, such as rheumatoid arthritis, Wegener's, or systemic lupus. You need to treat underlying and associated conditions. Patients got dryness, has to be treated before you operate on them. Diabetes, any lid abnormalities need to be managed. Any infections patients need to be diagnosed. You use preservative-free drops, especially with glaucoma, because they can be a culprit. And there are a variety of surgical techniques, but the perioperative immune suppression is a must. Thank you.
Thank you very much, Dr. Syed, for a very comprehensive talk. Any questions or comments for Dr. Syed? Yes, please.
So if you can, we all...
Dalia, can you repeat the question?
Yeah, how much oversizing? So we always try to oversize by 0.25 when we do grafts. But remember, it's all a percentage. So if you're making a smaller graft, the 0.25 is quite a lot. If you're making a bigger graft, a 0.25 is not too big. So if you're going to make limbus to limbus graft, you probably want to go with 0.5. Because also it reduces the chance of getting glaucoma. It opens up the angle. So 0.5 for large graft, 0.25 for smaller grafts.
In comprehensive ophthalmology practice, we are very scared of using topical steroids in the patient. So when not to use and when to use?
So one very important sign is if you see an AC reaction. If there is AC cells, then there is an element of infection. So, but if there is no AC cells, then you're most likely dealing with a PUK. If it's peripheral, no AC activity, you're dealing with a PUK. Use preservative-free steroids under cover of antibiotics. And if it's very, very thin and you're really worried, use systemic steroids. Use oral steroids. Then, you know, don't give topical. Sometimes I'm careful with topical. Give systemic steroids and monitor the patients. But obviously, you have to do your blood test before, so to know your baseline and to make sure that you don't have any systemic infections.
Any comment on the multiple use of antibiotics?
But if it's not infective, you don't need the antibiotic. See, the antibiotic is just to cover against the infection. If it's a peripheral ulcer and there is no cells in the AC, you're most likely dealing with a peripheral ulcerative keratitis.
Because in periphery we get patients from the village area. They come with 2-3 antibiotics.
So see that is a distinction you need to make. Like that you do not want to use antibiotics unnecessarily, because they will create resistance and they are not serving any purpose and they are increasing the cost of treatment to the patient. So if you are able to make a distinction, and most of the PUK making the distinction between infectious versus infectious, I'm sure Somsila will cover, but you know, not that very difficult even for a general ophthalmologist. So hopefully by after the end of the instruction course you'll understand those aspects.
Any role of topical cyclosporin eye drops?
I would probably use topical steroids and systemic steroids. A cyclosporin ocular surface inflammation, it's not, you need systemic treatment. All these patients had to be on long-term systemic treatment managed with the help of the rheumatologist. We are not really geared to monitor patients for systemic immune suppression. That's why you'll always have a rheumatologist somewhere in a nearby hospital where you can liaise, because these patients, their bloods have to be monitored, cyclosporin, they have to do a trough level, or tacrolimus, they have to do a trough level. So you can't really do this as an ophthalmologist in most centers. So liaise with the rheumatologist. Systemic immune suppression will maintain these patients with very good visions for years. And then if you have to take off the systemic immune suppression, then that has to be very gradual with you and the rheumatologist hand in hand.
Any other question, comments for
your steroid of choice for topical?
Excuse me?
Your choice of topical steroid is prednisolone or?
We use dexamethasone preservative free in England. I practice in Nottingham.
See, here I would use pred acetate, which is quite freely available. Dexamethasone preservative free or dexamethasone alone drops not easily available. And so pred acetate really works very well in this condition.
And treatment should be aggressive at the first and it has to be tapered afterwards.
Yes.
See, doctor, you are missing her point. She said repeatedly systemic treatment.
Yeah.
For PUK autoimmune, it is systemic. And we will cover that in detail in the next talk, but Dr. Jayes will cover.
Okay, thanks for a wonderful lecture, Dr. Syed.
Thank you.
How frequently we get basically a PUK in herpes simplex infections?
Herpes simplex does not cause PUK.
But
Herpes-
it has been seen the peripheral keratitis is caused by HSK as well, and they are treating it with it.
So the peripheral, herpetic infection can happen. This is an infective origin. So there are clues to the herpetic infection. First, there is loss of sensation. Second, there is the history of the patients having repeated herpetic infection, and then you don't want to get steroids if you have you might have KPs, you may have AC reaction, you'll have other signs of herpes. You're not going to present with a PUK like
Right now
this.
in the etiology of PUK, herpes simplex is a common etiology now.
We have a talk on differential diagnosis next. So
Okay. Thank you.
thank you so much. With that, I'll call upon Dr. Somshila Murthy, who is the director of the Shantilal Sanghvi Eye Institute at Mumbai, and she's going to speak on immunopathogenesis and differential diagnosis for PUK.
That is what they are pulling out.
So this is what is uploaded.
सोमशिला यही अपलोड किया आपने पहले. Okay, you can use that.
So they've just uploaded this one in this form.
You want to do some introduction? Achha.
There are two more left. नहीं.
Presentations
For the systemic treatment, I know most of you are a bit scared that you don't want to because you don't
So
know.
please use the mic. Please use the mic because record.
All right, I thought I'm loud enough. The systemic treatment, I suggest those of you who are very seriously interested in this area, learn to do yourself. It may sound very difficult, but it is not. Number two, if you are not very comfortable, find a good collagen vascular or a rheumatologist or hemato-oncologist who can collaborate and work with you. Not like just, okay, you refer, you see, but somebody who can listen to your feedback. That you say, okay, this patient has this kind of inflammation and it will perforate, or if it's already perforated, it means that it may affect the internal organs. So those are the kind of collaborations that you need to develop. Now I'll go back to Somshila. Are you ready?
Yep.
Please go ahead.
Very good afternoon to everyone, and thank you very much, Dr. Shah and Dr. Sangwan, to have me in this very, very interesting symposium on PUK. I'm so happy to see a full hall on such a rare subject. So, coming after such a beautiful talk by Dr. Dalia, it's my job is made partly simple also. So I'm going to cover the immunopathogenesis and differential diagnosis, the question that was asked. So what is PUK? It's classically immune mediated. That's what we've been hearing. It's a rare inflammatory condition involving the juxtalimbal corneal stroma, and probably you would heard Inisha's talk about the juxtalimbal corneal stroma. It can be either just the eye, or it can be associated with certain systemic immune mediated disorders. There's a high association with connective tissue disorders. In fact, nearly 50% of classic PUK that we see, they could be associated either with RA or with GPA, or even with PA and SLE, polyarthritis nodosa and SLE, which are much more rarer. And ocular manifestation can come before the systemic disease. In the etiopathology, I've tried to make it very simple so that we don't get bored. And then both the cell-mediated and a humoral immunity in conjunction with the corneal tissue destroying substances, which are those are the metalloproteises, the matrix metalloproteases. So all the immune systems are wired up and they start causing the inflammation. How does this happen? So we have the cell-mediated immunity which upregulates the CD4 cells, and they are also dysregulating the autoantibodies. They activate the autoantibodies with the humoral immunity which signals there's loss of the B cell tolerance to our own antigens. So the B cells think that this is a foreign antigen. The serum IgM start getting directed towards the natural IgGs. And in the case of certain diseases like RA, there are anti-CCP antibodies floating around. In GPA, there are ANC antibodies floating around. So all of these put together, they torture the cornea. So there is an upregulation of the matric metalloproteases and downregulation of the TIMPs. So there's especially increase in the collagenase activity, there's increased tissue destruction and ulceration. And overall, there's a decrease in the tissue repair. So this is how all of this put together, they start attacking the bichara cornea, the periphery. So that's why I always feel very sad for the cornea. So, and also I think you must have mentioned in your talk is that the limbus seems to, that the limbal architecture is such that it seems to be a watershed zone for all sorts of inflammatory cells coming there. So the relevance, why is it, if those of you who are general ophthalmologists or seeing a lot of patients, and some of them will come in with PUK, what's the relevance? So the pure immune-mediated PUK like the GPA, RA, you may not see that much on a daily basis at least. The Moran's ulcer, though rare, but you might see these cases occasionally. The PUK-like lesions, as a question was asked, you will definitely see these PUK-like lesions, and I'm going to bring up those. And luckily, though the associations with, say, rheumatoid arthritis or granulomatosis polyangiitis is rare, but you should be able to recognize them and refer them, unless you're anyway going to treat these patients, in which case you must get confident to treat with systemic immunomodulators. So coming to so one way to look at the differential diagnosis would be to sort of classify PUK, which I do in my mind. I think of the local causes. So am I looking at a local infection? So the question asked was, could HSV? So am I thinking of a local infection versus is it going to be a systemic immune-mediated disorder or even a local immune-mediated disorder? So under immune PUKs, pure immune PUKs, you can have the eye only or involving the body as well. The pure eye PUK is Moran's ulcer. So Moran's ulcer is nothing but a peripheral ulcerative keratitis in which the eye is the only organ that is involved. The eyes or the cornea is the only organ that is involved. So the slide at the bottom, whereas that is a case of bacterial keratitis with perforation. It is not PUK. The slide at the top is Moran's ulcer. So under the local causes, under infections, you can have even bacterial, fungal, viral, parasitic. Under non-infectious, something like trauma, or the lids and lashes. So I'll come to this in the mimickers of PUK. If they continuously keep rubbing a particular area, so if you're not very astute of it's not there all the time, a trichiatic eyelash going on rubbing the cornea, causing melting, some of us might think it's PUK. Under systemic causes, you can have immune-mediated, some dermatological conditions, and some systemic infections. This I've already covered. So under the non-infectious causes, to add on to complete the list, you can have traumatic, for example, peripheral corneal thinning in chemical, thermal, radiation, not during the acute phase, but as a healing. The eyelashes I had covered already. And about, in viral, there are two mechanisms. One is the neurotrophic part and the second is an acute infection. So again, to complete the list, this is just for completion. So we have all the autoimmune vasculitic disorders on your left side and a few dermatological conditions I mentioned earlier, such as cicatricial pemphigoid and Stevens-Johnson syndrome, which can also lead to a PUK or a PUK-like picture. But the immune-mediated disorders are in the ones on your left side. So the list just goes on a little bit more, even inflammatory bowel disease and certain systemic infections. I talked about eye infections mimicking PUK, but even patients with systemic tuberculosis and certain other diseases can also have a PUK-like picture. So in other words, we can divide the classification as due to inflammation, our mimicking conditions due to degenerative, and those conditions which are due to the bystander, like there's a corneal infection or scleritis, and then there's PUK. Coming to the infectious causes, this is a classic example that somebody mentioned earlier. And what I think the keynote speaker may have left, but what we're trying to say is that when you have marginal keratitis, so these patients come in, if we don't recognize it fast enough, you know what happens in viral, that there is a very rapid melt of the peripheral cornea. And when the patients come to us, sometimes it looks like PUK. So the differential diagnosis, look for corneal sensations. In spite of this much inflammation, patient doesn't look like patient is very distressed. And then when you see the grayish infiltrate leading that edge of the ulcer, that this does not happen in a classic PUK. This is another case which was actually referred as PUK, but this is actually bacterial keratitis. There's no way to know just looking at it. You need to go sequentially in the patient's history. The patient had acute infection, was on antibiotic. So there's no hypopion now, it's resolving. But you know, bacteria, it proliferates very fast, causing a lot of destruction. And so the patient presented with a perforated corneal ulcer. Only thing, it was in the periphery and therefore labeled as PUK. The flip side can also happen. So on your right side, you have a slide which shows a very advanced PUK. Look at the hypopion. That is very unusual. So this patient had bacterial keratitis in advanced Moran's ulcer. That can happen because it can be a secondary infection. Sometimes, if you're not very careful, so look at the slide on your left and on your right. Same patient. So the left side shows a typical lack of corneal luster. And so this is a patient we're looking at keratoconjunctivitis sicca. So that patient doesn't really have PUK, but there is desiccation of the cornea because of lack of tear film, and it looks like it starts melting. When you start steroids, when you start lubricants intensively for this patient, you will see that the Dellin effect rapidly sort of becomes much, much better. So this is not PUK, no need of systemic workup. It is dry eye. Investigate, of course, for RA, but for a different reason. And this, when you apply stain to the right eye, you'll see the staining areas. Even in the conjunctiva, you can pick up stain. One more case of cause of dry eye. This is a patient with secondary Sjogren's, presents with perforated ulcer, you can call it, or a sterile ulcer, and that is not PUK again. Some other mimickers which come to us as resolved PUK, Terriens is a great mimicker for that, because this is very advanced Terriens. You'll see all the white lipid-like deposits over here. But if you have a patient with early Terriens or an inferior Terriens, which is very unusual, so the eye looks very quiet and the patient may have had some congestion, but not really very severely symptomatic. So this is a classical case. See on the slit how this area looks very thinned out in the periphery, but this is Terriens. You can do pentacam and you get the classic image for that. Sometimes even PMCD, peripheral marginal corneal dystrophy, can mimic PUK, because again the periphery over here is very thin. So not all thinning appearances are PUKs. And this was a rare case which similar to one case Dr. Sangwan had handled way back. So this patient came with a peripheral ulceration like lesion and a lot of thinning. It's not visible here. And all of these white areas are actually keratic plaques. But if we don't think, because we are cornea specialists, so we may not automatically think of OSSN, we might miss the diagnosis. So that's all I had, because it's a shortage of time. And I'm practicing at a new center now for the time being, after practicing for donkey's years at Eli Prasad Institute. And this is my team over there who have helped me put together this presentation. Thank you very much. Thank you.
Thank you, Somsila. Please come join us here. Thank you very much, Somsila. Myself and Dr. Somsila have been in LVP for almost 20 years. And recently I moved to Delhi in about 5 years back. And Somsila is an authentic immunologist. She did a fellowship with Dr. Narsingh Rao way back in 2000 or 2001. So you have any questions, or we can go to next talk on the treatment by Dr. Jayesh Vajrani, who's a cornea specialist, ocular surface specialist, trained at PGI Chandigarh and a fellowship and faculty at LVP. And Jayesh, please.
Right. So good afternoon, everyone. My topic is medical management of peripheral ulcerative keratitis, and these are my financial disclosures. So the definition we've gone through, we know that PUK can be associated with inflammation of the adjacent tissue, sometimes can also have uveitis. The pathogenesis has been covered in great detail, and why peripheral cornea, that has also been discussed, so I'm not going through it again. Right, so let me just start with some cases. So this is a 43-year-old man who has symptoms for about a week in the right eye, and the left eye he has had low vision for many years. So we can see that there is a peripheral ulceration in the right eye, in the nasal periphery of the cornea, and the other eye also seems to have had some sort of perforation which has healed, and now the patient has an adherent glaucoma. So this is case 1. Case 2 is a slightly older woman who has had symptoms for about 2 weeks, and you can see a very classical looking furrow or a peripheral ulcer with some infiltration, thinning, and there is congestion in the eye. And this is how the other case 2 looks. This is case 3. So pseudophakic both eyes and has large perforation with iris prolapse in the right eye. The other eye is also showing thinning in the corneal periphery in the inferior half. Right. So please keep these 3 cases in mind. So how would we proceed with this? So it has been outlined in the earlier talks that there is a protocol for this. It's very logical what to do. So the first thing we do is ask some questions which may be pertinent for the eye, as well as if the patient has any systemic involvement, which we usually look for when we look at PUK. And then you do some targeted investigations. Not all of these are always necessary, as Isha had pointed out. One can do a basic screening, and then based on the clinical manifestation, systemic as well as the ocular, and then go to the other investigations. All of this is there in the handout, which the QR code, you can just scan and get it. So these are the typical signs that you look for. You look for the joints, you look at the skin, you look for nodules, you look at the teeth, the salivary function, and then you also ask some questions about if the patient has any visceral involvement. Why? Because we know that a lot of etiologies of peripheral ulcerative keratitis do have systemic correlates, and the commonest that we see in our clinics is rheumatoid arthritis. The second commonest is ANCA vasculitis, but then you can have a lot of others which other speakers have shown. And this has already been discussed, that apart from the systemic issues, you can have local causes, so that can be infectious or non-infectious. And these are the specific laboratory tests for each condition, but we don't need to go into this. So this was the first case. So you can see that if you look at the patient, he has a rash, there's a skin rash, it looks very erythematous, there is a facial skin rash. He's had a very interesting and complicated history. He has had arthritis, septic arthritis was the diagnosis. He was admitted with a fever of unknown origin, and he's had multiple organ involvement over the past 2 to 3 years before he came to me. The Sherman test shows reduced tear production, and also he has this kind of corneal picture. The second case, the lady that I talked about had very obvious joint deformities in both the hands as well as the toes. She had dry mouth and very highly raised RA factor. So when you see this, what you're looking at in both of these cases is PUK associated with a systemic disease. It was rheumatoid arthritis in this case, case 2. In the first case, the rheumatologist felt it was an overlap between RA and SLE. So there's an overlap where cases can have features of lupus as well as rheumatoid arthritis, and that gentleman had an overlap of RA and SLE. So the management is medical as well as surgical. So medical therapy can be local and systemic. Systemic therapy, as has been emphasized throughout this course, is critical and very important. So the systemic therapy can be done in 2 ways. As Dr. Sangwan was suggesting, if you are really interested and you have the inclination, you may want to train yourself, and if you're trained well enough, it's not very difficult to figure out which severity, which cases, how severe it is, and what kind of drug to use. However, if you feel that you need the support of someone, these days it's not very difficult to find rheumatologists in almost every major or even slightly smaller cities. So you just need to take them on board and convince them that despite the patient may or may not having systemic manifestations of disease, the eye disease is severe enough to warrant systemic therapy. So the medical therapy is the key part here, and the other things are adjunctive. So if you do just surgery, it is going to fail. So if you want to do surgery, it should be done under the cover of appropriate systemic therapy. And why is it important? Because as Dr. Sangwan was alluding earlier, these patients, and there is a lot of evidence, so this paper is older than I am, but it basically says that if a patient has PUK or scleritis, and the patient has a systemic disease, and that patient is not treated systemically and not treated aggressively enough, it's very likely that the patient will not survive over the next 5 years. So the patient will die, forget about the eye. So even for that reason, the patient needs to be on systemic immunomodulatory therapy. What are the drugs that we use? There are quite a few, but you can categorize them into mainly these agents. The most important and the ones of immediate use are corticosteroids. That will buy you time for you to use another drug. And then you have alkylating agents, antimetabolites, T-cell inhibitors, biologic agents, and these are the newer ones, the JAK-STAT inhibitors. So the general principle is you match the severity of the condition with the drug that you want to use. So if you have a case where the globe integrity is threatened, so you have a PUK which is perforated or is about to perforate, you also have necrotizing scleritis, you don't really have time for the slower acting drugs. So you need to give them a reasonably high dose of systemic corticosteroids. Usually we use intravenous methylprednisolone, 500 milligrams to 1 gram a day, and you repeat it over the next 2 days, so about 3 days. Simultaneously, the drug of choice for these cases has traditionally been cyclophosphamide. So it was earlier very long ago given orally, now is usually given in intravenous pulses. So you give intravenous cyclophosphamide. An alternative to this is a CD20 inhibitor called rituximab, but cyclophosphamide is much cheaper. And then once you have achieved a sufficient degree of control over the inflammation, you may want to switch over to oral steroids in tapering doses, and the tapering needs to be reasonably slow. And then once you have, let's say, given 6 pulses of cyclophosphamide, one usually tries to step down to something like mycophenolate or azathioprine or methotrexate for maintenance of the remission. There is a certain degree of monitoring involved of the liver parameters, the renal parameters, as well as the blood pressure, blood counts, because some of them can have bone marrow toxicity, some can have toxicity on the liver and kidney, but this is not very difficult to do. So drug-specific serum levels are needed, as Dr. Syed was alluding to, for T-cell inhibitors, cyclosporin and tacrolimus, but this is only when you use them in very high doses, the doses that are typically used to prevent organ transplant rejection. For the doses that we need in the eye, there is some literature to suggest that you need not monitor the serum levels. So I'll come to, for example, this case, as I was saying, here the globe integrity is threatened. So here this is the this is the regime that I used. So IVMP 500 milligrams for 3 days, followed by oral prednisolone 1 milligram per kg, and this is tapered over 2 to 3 months. The patient is given pulses of intravenous cyclophosphamide, and once the eye is quiet, one can shift to a milder drug. And then with appropriate therapy, it quietens down. So you don't really need surgery, even for cases where you feel that it's a very bad case. If you don't have an imminent perforation, then one might want to give just oral prednisolone to begin with, and then taper it slowly and match the severity of disease with an appropriate immunosuppressive drug. So for these 2 cases, what we did was we did not use intravenous steroids, we used oral prednisolone, and both the cases simultaneously methotrexate was started. Methotrexate acts well for rheumatoid arthritis in general and also for PUK associated with RA, but it takes time. So it's not as quick as cyclophosphamide. This was the 3rd case. Here everything was negative. So all the labs were negative, and Dr. Sangwan told you about Watson's criteria for Murren's ulcer. So this is bilateral Murren's ulcer, and there also there is a stepwise treatment protocol. I'll go back.
This is what I was referring. These exactly are the 5 criteria, and that was proved. He initiated them clinically, but then it was proved by a study from Arvind and a group in US with a prospective study. And now if you understand these, then you don't really need to do a systemic investigation. Thank you, Jace.
Right. So Murren's ulcer, this is a free article in IGO, and now there are more recent articles, but more or less the protocol remains the same, that you have a step ladder approach to treatment. So starting from topical steroids, going on to conjunctival dissection, systemic immunosuppression, additional tectonic surgeries, and then rehabilitation. So this case, again, we gave IVMP for 3 consecutive days, and then oral prednisolone, cyclophosphamide pulses. And after we had given IVMP and the first dose of cyclophosphamide, did we operate? So the patch graft was done after and not before, and that is important, right? So the differential diagnosis Dr. Murthy has talked about. So this again is HSV associated ulceration, which looks similar to a PUK. One may have associated lid margin disease, and you can have recurrent or chronic blepharokeratoconjunctivitis, which leads to peripheral scarring, sometimes peripheral inflammation and thinning, that can also mimic a PUK. So here the treatment is local. If you have HSV, you need to treat appropriately with antivirals and sometimes steroids, depending on the tissue involved. If you have chronic blepharokeratoconjunctivitis, you look at the cause of the blepharitis, whether it is anterior or posterior. A lot of these cases are associated with Demodex infestation, so you want to treat that. And then give topical steroids, and usually it quietens down. So these cases do not need systemic therapy. So the take-home messages from this talk would be that PUK is an inflammatory corneal disorder driven usually by systemic autoimmunity. It is often accompanied by episcleritis, scleritis, and sometimes even uveitis. Murren's ulcer is when you don't have any systemic associations, but systemic evaluation is essential. So for both the evaluation and the therapy, you need to determine whether you are equipped to do it or not. So my suggestion is that if you see these cases very rarely, it is best to send these patients as early as possible to the nearest ocular surface specialist or cornea specialist who knows what to do. And they in turn may want to treat this themselves, or they may want to liaise with a physician or a rheumatologist. And once things are quietened down, the patient can be shifted back to the comprehensive ophthalmologist for monitoring and follow-up. Right. So I'll just plug a few things here before ending my talk. So we've been doing a very interesting meeting called Ask Me Anything, AMA, at Ahmedabad since 2018, which focuses on ocular surface and corneal issues. And last year we combined it with another meeting called the Ocular Surface Workshop. So it was OSW AMA. This year again we'll be doing it in September at Ahmedabad. So it is comprehensive ophthalmologists are welcome to attend. Some of the things are a little advanced, but I'm sure you'll find something useful. But definitely if you're a cornea specialist or an ocular surface specialist, you'll find it a very good meeting. So it's very informal, non-hierarchical, and everything is very clinically relevant. And this year we've decided that it is going to be a no-text meeting. So we are going to stipulate to all the speakers that you are not allowed to use any text on any of your slides. So it's going to be a very interesting meeting. We also have an observership program at Ahmedabad. So if you feel you have any young people who are interested in cornea and ocular surface, this is not a long-term fellowship, so there's no surgical exposure, but a lot of clinical exposure, and they get to know all the protocols. So that is the QR code for the observership program. And with that, I'll say thank you very much.
Thank you, Dr. Jayesh, for a very comprehensive and interesting talk. Yeah, the mic's working, yeah.
Any questions from the yes? Second last slide. Could you please observership program?
Can you put up his slides again?
Doctor, can you please use the mic just behind you? Yeah.
The Ask Me Anything program, is it a hybrid program or?
No, it is not. By design, it is not hybrid. Okay. We don't even record it as a video. Okay. So if you want to be there and ask me anything, you have to be there.
Okay. So right. Every year it's in Ahmedabad only? Or?
Yes. The OSW has not always, it has been traditionally at LV Prasad Eye Institute, Hyderabad, and it will probably return to Hyderabad later, but this year it will be in Ahmedabad.
So any questions?
You can just meet me. I think we don't need to put up those, and I'll give you the links to either the QR codes, yes.
So before we have the last speaker, questions regarding...
He also wants to see some slide. Which slide?
Last slide.
I'll give it to you. I'll give you
the details.
Right. Please.
Role of tacrolimus. So tacrolimus traditionally, at least in my practice, I have used at least over the past 7 to 8 years extensively for ocular allergy. Personally, I have not used much for PUK or scleritis, but the rheumatologist that I liaise with saw me using tacrolimus for allergy, and she's saying that she adds it to cases of recalcitrant scleritis or even PUK, where they're not subsiding with methotrexate or azathioprine, and apparently it is very good. So T-cell inhibitors also work.
Is a question about topical tacrolimus?
Okay, I misunderstood. I'm sorry. We really don't think in terms of eye drops for these cases, so it's my mistake.
See,
right.
This is a disconnect.
Right.
When we are talking about PUK, we are talking mostly systemic.
I just assumed you were asking about tacrolimus tablets, but topical tacrolimus, no role. No role.
So what all of us are agreed on, at least on this side, is that PUK is a systemic disease. So the driver is systemic. So we have to suppress it systemically, of course, barring the infections and the local causes. So the pure PUK, whether it is murines or it is with an autoimmune disease like rheumatoid arthritis and so on, or you cannot find the autoimmune disease and it's not looking like murines, but you have PUKs. All these three categories need systemic immunosuppression. So when you talked about tacrolimus, he thought immediately that you were saying systemic, and I knew where you're getting at, because we do.
So madam looks a bit scared with the talk of all these drugs. So, but if these are just drugs, like you use Dimox or you use antibiotics.
Dr. Sangwan, but here I would tend to slightly disagree, in the sense that when you said you should learn by yourselves, yeah, that is good, you can, but I think that so that the ophthalmologist or the specialist can focus more on their practice, it would be very good to have a very nice partnership. Not everybody is Dr. Sangwan here, so it would be, there's no other Dr. Sangwan.
I will tell you the story.
But so just to complete that, it would be good to have a very good sort of a partner. And it's, sometimes we have our colleagues, we have people from our own batch or whoever we have, find that kind of partner, or the medical colleges and so on. And over a period of time, when you develop that connection, then you can have the systemic part of it, they really help you with that. And they do know more than what we know. Like tacrolimus, for example, your rheumatologist pointed that out, and you wouldn't have had the benefit of that. And we are still sort of backdated with whatever drugs we used. And now they have moved forward and they use various other drugs which can be helpful to our patients as well. So I have a patient of rheumatoid arthritis with scleritis and PUK, and now what is really helping her is tofacitinib. On my own, I would have never started it.
Yep. Thank you.
For Jayesh. Thank you very much. I self-introduce myself. I want to tell you a story, why I started learning PUK or ocular inflammation myself. When I was doing fellowship in 92 with Dr. Rao, at that time I had a patient from Odisha, a young lady with rheumatoid arthritis with corneal perforation, and she was sent for a PK. When we examined her, she had active perforation with hypopyon, with swollen joint, with 135 ESR. So when Dr. Rao said, please take this lady to NIMS, rheumatologist, and if we don't treat, she may die of vasculitis. So I took to NIMS. There is a doctor, very big HOD, and he saw and he did all investigation. He says, nothing active systemically. She doesn't have an RA. Only ESR is raised. And so he said, nothing, I can't give systemic treatment. So I bring back to Dr. Rao, and he gets very angry. He said, you have no idea, this lady will die. And I said, but he refused that there is nothing systemically. So then sent me back that you pull out the literature and then throw these letters on the professor's face. I said, sir, I can't do, I'm a very small fellow, I can't do these things. I went again, showed him the literature. He said, if you have the literature, why don't you treat? We can't treat because it's not systemically active. So in that process, what I realized on that day, that both the doctors have right intention, but Dr. Rao did not know how to treat systemically, and the rheumatologist did not know ophthalmological manifestation is as equally important. So sometimes we have to take little extra step. Now, of course, the situation is slightly better in our country, that there are more rheumatologists, and if you can find good one who can listen to you, is very helpful. Can I have my slides, please?
What was the final outcome?
Final outcome, I mean, we did not give, only we gave a systemic steroids, and we did treat ourselves. Rheumatologists did not. Another example, when I came back from US in 98, there was a patient of Wagner's. I sent to a rheumatologist. He called me, he says, Dr. Saab, ये तो मैंने किताब में पढ़ा है, पेशेंट कभी नहीं देखा, तो मैं क्या करूँ इसका? मैंने कहा सर आप ना इसका सिस्टमिक देख लो, बाकी मैं संभाल लूँगा. तो उनको सिस्टमिक ट्रीटमेंट I started doing myself, and that's why that if you want to treat these patients and they are predominantly eye patient, I think it's the responsibility of ophthalmologist, or find a good solution to that. All right, I'll talk surgical management. So this is I said you this in the introduction slide. So this was, the patient gave a history of some another surgery, details were not known, and we did a patch graft, and we sent the tissue which was excised, and this is what the outcome was. Not only this, this is what happened. After the surgery, it started going downhill, and essentially then we lost that eye. So now sometimes you may feel that maybe you, if you did not do anything, probably you would have not caused this, but we did save his life, because he had a infiltrating carcinoma, and which has the potential to not only spread to the eye, it could have gone to the rest of the body also. This was the histopathological evidence. This is a patient I managed in 2001, had a history of pterygium surgery. This gentleman comes from Rajasthan, and when you see this, immediately you will get scared that yes, oh, this is a perforation, there is a uveal show, I must do immediately something about it. But there is remarkable if things you've noticed. They are metastatic lesions, the yellowish infiltrates, and it's very neat and clean. There is no discharge. So there is no question that it is infectious. It's not possible that it is infectious, right? So now here it's very important to understand, if I do a patch graft now first, then the same process, inflammatory process, will melt that graft also. So what was the key? To treat the patient systemically after doing a basic investigation and then do a patch graft. So I treated him with the IV cyclophosphamide, IV methylprednisolone, then oral for 6 weeks, and then went ahead and did a scleral patch graft. And this continued the treatment for next 1 year and followed it very closely every 2 to 3 months with the CBC and LFT RBS. And later he underwent a cataract surgery in the same eye, and the vision improved. Best corrected vision was 20/25 in that eye. So it's not that you cannot salvage these kind of eyes. This is a patient which was diagnosed as Moran's ulcer for several years and treated as it is. And when it presented to us, we suspected that it doesn't look like a Moran's ulcer. You agree that now looking at the pictures that it does not fulfill Watson's criteria. Clinically it doesn't look like a PUK. So it was a carcinoma, and he underwent a orbital, EVCRC and after exenteration. This is a standard patient with rheumatoid arthritis with small peripheral perforation, with systemic treatment and the patch graft and healed very well. Another interesting case, a 15-year-old girl referred from J&K. She had consulted 5 other doctors. She was diagnosed as VKC, received a supratarsal steroid injection, and there was a tarsal necrosis. If you see here, there is a tarsal necrosis on the site where injection was given. And for me, this was very remarkable. I never seen this kind of presentation. She also had a elevated mass, a peripheral ulceration, AC inflammation, KPs. I had no idea what it is. Therefore, I removed that mass, put TABCL, put amniotic membrane on top, took AC tap, and also sent the tissue for histopathology, and suspecting that there is something weird. And what it turns out to be? This turns out to be a Mycobacterium tuberculosis. This was a conjunctival Mycobacterium tuberculosis, when she was treated with systemic ATT for 8 months, and she recovered completely. This is a very instructive patient. I encountered very early in my career at LVP. This was a Moran's ulcer or some sort of PUK, and one of my colleagues did a patch graft, and we did not immunosuppress because thinking that it doesn't look very aggressive. And within 4 or 5 weeks, the patient comes back with this kind of inflammation. The patch graft is gone, and it is clearly that the immune process has eaten away the graft completely, and now at this stage giving him IV methylprednisolone and all that, not very beneficial, because most of the cornea is destroyed anyway. I'll skip this part because we have seen enough of it. So the fundamental treatment for surgical treatment for is the conjunctival resection, TABCL, and if you have the histopathology or immunopathology, please do the histopathology and immunopathology of those tissues. And if you have a perforation, do a patch graft. But these patients would need some sort of immunosuppression, immunomodulation. These are the examples of patch graft. On the lower side, this is a rabbit model of a corneal scar or neurotrophic keratitis, which we are developing, and it's a liquid cornea. And what I am thinking, that if I have to do a patch graft, once I have this material, after removing this diseased tissue, I can just use this liquid cornea and create that mass. And since it does not have keratocyte, it will not be subjected to immune mediated inflammation. So I am thinking that instead of doing a complicated patch graft, in future I may be able to treat this with the liquid cornea with mesenchymal cells or with exosomes derived from the mesenchymal cells. This is another way of doing the patch graft, that there is a perforation, not only central perforation, then lamellar. So centrally we will seal the perforation first and then do a patch graft. And this was shown by Dahlia as well, about how to do a patch graft. And if you are a corneal specialist, doing the patch graft probably little more complicated than PK, but it is doable. So you do lamellar dissection depending on the thinning that you notice. These are very small number of patients that we have looked at the patch graft in LVP at that time. And if you use systemic immunosuppression, the outcome of these surgeries is not that bad. This is a patient of Moran's ulcer. Now this is this is the same video. I will skip. This is the same video that I showed you for the tuberculosis, but this is just showing the technique of conjunctival resection. Conjunctival resection, you want to do at least 1 clock hour on either side of the lesion, and you want to cover the healthy part as well, 1 clock hour. This is a Moran's ulcer where you have a central island remaining. So it was a pediatric patient. So what I did was I removed the central island, and then you don't need systemic immunosuppression because whole of the stroma is destroyed. The other video I am showing you, if I have this patient and if I have that liquid cornea, I will not do this procedure. I will remove it and fill with the liquid cornea, and hopefully will reconstitute the stroma. Then in around 2010-2011, we started doing patients with bilateral Moran's who have failed several PKs, Boston type 1 keratoprosthesis. Because in these patients, the PKP really does not work well. And these are the example of patients with the bilateral limbal stem cell deficiency due to Moran's ulcer and VKC. And this is one patient who underwent the Boston type 1 Kpro and received systemic methotrexate, and this worked for several years. Then there was always a question, can the cataract surgery be safe? Because in the literature, it's very commonly believed that if you do surgery, it can initiate the Moran's ulcer reactivation. I don't think that is really true, and therefore I have been doing the cataract surgery in Moran's ulcer from very early on. This was the case report in JCRS in 2005, where we've done 2 or 3 patients, and this is an example of a ECC in a patient with the healed Moran's ulcer. This is a more recent example of a healed Moran's ulcer, and I'm doing a phacoemulsification. So the surgical technique, or it really does not matter whether you do scleral, like I do prefer all cataract surgeries, posterior limbal incision, don't need to be clear corneal or avoiding cornea. I don't think it makes any difference. After that, we have published a large series of patients of treatment of cataract surgery in Moran's ulcer, and it was published in Cornea, around 22 patients, 26 eyes. The technique wise, I use where possible phaco is the first choice if I can do it. If not, then ECC or SICS. You must have seen the IOL was very different. It's the IOL that I had designed with the IOCare. When you have pupil which is damaged, especially in uveitis patient and other conditions, so I designed an IOL with 3 millimeter pupil. Rest of this PMMA is pigmented, so there is no light, too much light going into the eye. And these patients have done well post cataract surgery. This is another example of a patient. His half the cornea is remaining, but still from that he is able to see 20/50. We cannot overemphasize the value of immune modulation. It's very, very important that we either use ourselves or we collaborate with a rheumatologist, hemato-oncologist, immunologist, whosoever that you can find. And these are some of the step-ladder algorithm published in the literature. And there is a very large study published from one from Arvind, one from China, and another from LVP of Moran's ulcer. The treatment, the outcomes are really well reported, and we understand this disease much better now. This is a pediatric Moran's ulcer that we had published in 2012 in BJO, the management, and we use systemic treatment there also, because in pediatric you use the immunomodulation in the doses that is prescribed for them. So in summary, the PUK, immune-mediated PUK is not very uncommon, and the treatment part, medical part comes the first, and then the surgical part, and where relevant. We must remember that a planned PK does not work. If you have to do a patch graft, or if you have to do a therapeutic PK for perforation, that may be different. If in bilateral end stage LSCD due to Moran's, Boston type 1 is a good option. Cataract surgery is quite safe and effective in these patients. Thank you very much. This is the, if you want to scan the handout which Isha showed on her presentation. So those of you who came later would like to download the handout which is prepared very nicely, and we'll be happy to take more questions if there are any.
Thank you very much, Dr. Sangwan, for a wonderful talk on surgical management. So all of you who want to know more about how Dr. Sangwan works and how his mind works, I'm sure a lot of you will know that now his biography is out. It is called Unbound. It is available online and offline. So you can find it on Amazon, and I highly recommend that all of you should read this.
Thank you, Jais.
Sagwan sir, thank you very much for beautiful insight of this PUK management. I have few questions about this. First, the majority of the PUK cases associated with rheumatoid arthritis especially, we see that there is a severe dry.
Yes.
It includes the filamentary keratitis also.
Yes.
So what you recommend in that case of filamentary keratitis, about the topical medication especially? I want to know about what is the role of the vitamin C and what is the role of N-acetylcysteine. Do you use this? You have the experience?
I don't use.
Second thing about the role of stem cells in this case of the PUK management.
So, okay, first easier thing, the stem cell in dry eye or in this PUK at the moment not a good idea, but I have been thinking about an idea for PUK or Moran's using the mesenchymal cells. However, I have not used because they are not that easily available. For dry eye or the filamentary keratitis, I think the best in my hand works is topical steroids, lubricant, and a Prose lens or a Boston scleral lens. And we have now that Boston scleral lens made in India in LVP available to all of us. Very helpful because it's filled with the liquid.
Any suggestion about the lubricating, especially any lubrication in this for?
Whichever you can find which is preservative free and patient tolerates well.
Okay. Thank you.
Thank you. Yes, doctor. Doctor asked if do we need to use any systemic steroids before patient is taken up for cataract surgery. No, if the patient's condition is controlled without any medication and stable for at least 3 months, I don't start any systemic treatment or topical treatment just because I am doing cataract surgery. If somebody is already on a maintenance dose of immunomodulation, I will not increase, I'll just continue to use and do the surgery. And if I find that more than usual inflammation on day 1, then I will increase the doses. Otherwise, not required for any of the inflammatory diseases. Thank you. Any other questions? We need to vacate the hall for the next session. Thank you very much. You have been very, very kind and considerate. Thank you. Do you want to have pictures? Yes, please come.